So this is the first of a series of webinars that we'll be doing. So we just encountered our first technical glitch, but we appreciate you coming on, and we hope to enlighten you all with the different treatment pathways that we have for our patients and different treatment options that are available as well. And we're also going to be open to taking suggestions. About different treatment that maybe our patients hear about, or anyone really in the community has heard about within the space of pain management that we can discuss. So overall, we hope this is a good educational experience for anyone that has the time to join us, and we appreciate that. No disclosures for us to give during these encounters and these conversations. So what are the current trends in pain management, Dr. Burnett?
Yeah, so regarding current trends in pain management, especially with the technological improvements that's occurred over the last 5 to 10 years, really, has been the advancements made in neuromodulation or nerve stimulation, both at the level of spinal cord stimulation as well as peripheral nerve or nerves outside the spinal cord and stimulating those nerves. And with the advancements made in these technologies, it's something that ourselves here at Macomb Pain Management really want to explore and offer to patients, because oftentimes they're a group of treatments that are overlooked by many fields, and just trying to increase awareness at those and how helpful and life-changing those can be for patients.
So some of the main, point of discussion today or webinar is the use of what we call spinal cord stimulation or peripheral nerve stimulation, and we'll kind of go through some of the actual devices themselves and how they're used. But generally speaking, some of the indications for this type of treatment are painful diabetic neuropathy, patients who've had back surgery and have chronic pain that has developed post-surgical. Whether it's neuropathic pain or general pain that often does radiate down the legs. We've been using it for treatments for chronic back pain that's not necessarily irradiating. Patients who've had injuries, for example, to their arms, legs, or feet. We've been using some of these devices to help mitigate and minimize the pain response and reduce the actual pain response. And then, nerve injury. So there's patients that have specific nerve injuries that come to us where we actually have to intervene. A lot of them are on medication management, and our goal is to help, reduce the amount of medications used with the use of some of these newer technologies that have come out. And lastly is joint pain. Joint pain is something that's relatively recent in the last few years. It has been used more often for shoulder pain, knee pain, and even ankle and foot pain. And so these are some of the devices that we are going to briefly discuss as some of the newer interventional methods.
Yeah, so oftentimes, when patients have these different type of nerve pain injuries, and we're going to use, because spinal cord and peripheral nerve stimulation, we're going to use different neuropathic pain conditions or nerve pain issues. It's kind of the basis as we walk through a discussion about these treatments. But oftentimes we'll start off with more conservative treatments with, different ways of mitigating the pain through medications or orally or topical medications. Additionally, things like TENS units or devices that you can put on the skin to stimulate, or ultrasound devices to help treat these nerve pain issues. These treatments are, well tolerated and can be quite helpful for patients, but unfortunately, sometimes the issue at the level of the nerve is either deeper down, or patients don't enjoy the side effects that may come with some of these medications. So we once we maximize or explore these less interventional treatments, we start looking at more advanced treatments or interventional approaches, such as the nerve stimulation treatments that Dr. Musabi already brought up here.
So what are the uses that we have? So we can kind of jump right into some of these devices that are used. So when we talk about painful diabetic neuropathy pain, a pain from post-spinal, surgical pain, and various other types of neuropathic pain, these are some of the different devices that are being utilized right now, where we use certain devices such as neurostimulation to help deaden the pain response, or almost like confusing the spine of not having the pain that the patient is experiencing. So these are some of the devices that are used to help minimize the pain response. That's more of the spinal canal use. And then we also have stuff like the nerves in the legs, for example. Someone who has an ankle and foot injury, we often can deaden the nerve response here that can help minimize the pain response in the leg. And
this can barely be seen. This can barely be seen, but this is what's called a lead. And these leads are used to be placed next to the nerve to help stimulate or block the pain coming from those nerves.
And some of these technologies that we're using these days have been recently approved by the FDA for issues like painful diabetic neuropathy, where for previous years we really didn't have many treatment options for except medication management and blood sugar control. Patients who also have injuries, for example, to their legs or hand and arms, also we were typically managing with medication management, but some of these interventional devices that we would use for the patient can actually help. That has been recently approved by many FDA as well as many insurances. So, and how does spinal cord stimulator work? So again, our bodies transmit pain through our spinal cord or spinal canal into the brain, the central kind of pain center, and that basically elicits pain. So if we can deaden that or eliminate that pain response, then the patient has less pain. For example, if you've had back surgery done and the nerves in your spine are, still irritated and or because of scar tissue formation develop pain, there's a way that we can actually deaden this pain and leg pain response, because these little wires that we place in your epidural space can basically confuse the signals of pain that are elicited or transmitted to the brain. So then the patient, instead of feeling pain, they actually feel something different. They feel a more soothing response, a less sharp response, etc. And similarly for peripheral nerve stimulation, Dr. Bennett.
Yeah, you can target the nerves at several different areas. Traditionally in the spinal canal with spinal cord stimulation, and that's been used for many, many years. More recently, you can use these same type of techniques with these small little wires and stimulators here, and you can place those in the leg, in the shoulder, in some of the joints of the low back, and that can help block those pain signals as well. Oftentimes, I like to think about it as in when we have an issue with our back, or we have the disc bulges out, pushes on the nerve, and compresses the nerve. Oftentimes people think we do surgery to open up that space and the problem is solved. Unfortunately, sometimes the nerve gets damaged. Sometimes the nerve is injured, and that injury, is a long-lasting injury in which, even though the compression on that nerve is not there anymore, the damage to that nerve already occurred. So how do we calm that nerve down, or how do we quiet those signals? And that's where the stimulation comes in. With peripheral nervous stimulation, you capture the nerve at the level of the leg or at the level of the ankle, as opposed to in the spinal canal itself. And when someone's pain issue is very specific to a certain area, say their left knee, instead of stimulating them at the level of their spine, it's much easier to address that issue locally at the knee itself.
So many patients ask or often come to us and ask, are we good candidates for this treatment? A lot of it depends on the pain history of why they're having the pain. And secondly, when we select the patient to say that this might be a good option for them, we do what's called a trial first. So we have the patient come into our office, and whether it's in the spinal canal area or whether it's along a nerve, for example, in the leg, we actually put one of these little wires and we actually put it into that space, and we leave it in there for a course of maybe 4 to 5 days, sometimes up to 7 days. And we send the patient home with either an externalized battery like this or something a little different. It depends. Each company has a different kind of a programmer. And then when we send the patient home with this, they utilize it for that course of the few days that we have it in there. And they let us know if their pain has reduced greater than 50%. Their improvement, has been seen in their function, ability to walk, less pain, maybe less use of pain medication. For us, that's a good and positive trial. So then we discuss with the patient, what are the next steps? So we see the patient back in the clinic. We actually, in the clinic office, or there's a simple room, we just remove the wires from wherever they're sitting, because they're just fixated in there. They're not permanently placed. And then we discuss about permanent placement. And permanent placement is done in a slightly different setting. When we do the trials, we do it in our office. And the permanent placement is done in a different setting, like a surgery center, which we take to our surgery center in Rochester. And then once we kind of get to that stage, Dr. Burnett, you want to explain kind of how the permanent implant works?
The permanent implant really comes down to a couple different things. Each patient has a different requirement for their pain, and there are several different options. There are a handful of different companies. We have a couple of these devices here, and they have batteries that provide stimulation to those little wires that we place. You can either place these batteries under the skin in the body, and that stays under your body, and it can recharge kind of like your iPhone charges with a wireless charging device that you place over that. Or you can have a more external battery, say like this, and it's placed over a receiver. So for more peripheral stimulation or stimulation of the knee, something like this device can be placed over the area, or there's other ways of placing it. The external battery can be on a band that goes over the area where the stimulator is, the receiver for the stimulator is under the skin, and that provides the stimulation to those wires. The benefit of having a battery like this implanted in you or a receiver like this implanted in you comes from many different aspects. Sometimes you want the battery implanted because there are conveniences to those. Sometimes you want just a generator planted based on the location of the issue and what type of stimulation we're trying to provide.
So, and I think that Dr. Bennett is making a great point. So the variety of different options that are available, the encounter that we have with the patient prior to moving forward, we look at all the variables. The convenience of whether a patient wants something that is externalized versus something that is more internalized. How and even within the space, there's different companies that offer different technologies. So we make the plan very unique and specific to the patient. So that is part of the discussion of even pre-trialing is, if there's an interest, then we discuss, what device we're going to use, what are the approaches that we're going to take. We every patient goes through what's called a behavioral assessment. So we look to see cognitively, as a patient capable of understanding how to manage one of these devices. So there's a thought process involved here that takes place prior to actually moving forward with the trial and getting this approved. Most insurances have a mechanism for approval. We work very closely with the insurances of the patients to help them with this process. Otherwise, it's a great technique. We've seen very good success with it. We're happy to share more of this type of technology, these advancements with our patients. We make it a point to discuss it, when appropriate.
Mm-hmm. Yeah, I think from my standpoint, the greatest thing with this type of treatment is that you really have few few treatments in medicine where you actually get to try something to see how it's going to work out before you move forward with that process, especially when we're in the realm of pain management or in the realm of surgical intervention for, say, a knee replacement or a back surgery. And you go into a lot of those procedures expecting one thing and coming out with another thing, or expect with certain expectations or unknown expectations. And with stimulation, you really get to try it before you move forward with it. And that's where that trial period comes into play, to really give the actual experience of what this type of treatment can provide for you without having to undergo a full implant of it until you're ready for that.
Yeah, I think that's a very good point. The trial period kind of gives the patient an opportunity to see if this is even going to work for them. So it's non-committal, but at the same time could be really life-changing for a lot of patients. So we appreciate you all for taking the time to join us. I know that, there's a lot of information, but we'll be happy to discuss it with any patient that has interest. And we're happy to field any questions right now if you have any. And you can just put them in the chat group, and we can respond. So the question comes up is, do all insurances cover this? So there's not every insurance will cover this, and this is just kind of how the system is, but we look to help the patient getting this approved. So we work with the insurance companies at various levels, but most commercial insurance companies do often cover this, so again, that's part of this process of moving forward with something like the trial, is that we go through the motions of getting the approvals.
One question that gets asked quite frequently to me is, why would I have some stimulator placed when I could go forward and have a surgery to replace a certain part of my body or fix the issue? Because people may think that it is more of a Band-Aid. And I don't like thinking about it in that way, because I don't think it's completely accurate. I think a lot of times, we want to think of, a surgery will replace this part of our body, like our knee, or open up a space like in our back. But unfortunately, a lot of times, especially with the back, is that some of the damage that's been done for the compression on the nerves has happened for many days, if not months, if not years. And even opening up that space will still will improve some symptoms, but we'll still have some of that pain. And that's where this type of treatment can be quite helpful. Or many times, frankly, at least 30% of my patients have already had a back surgery or have already had a knee surgery to fix something. And yes, it may have improved upon the anatomy or the alignment of something in the back or in the knee or in the shoulder, but the nerves have been conditioned to be firing these pain signals, and we're not quite able to overcome it with just that surgical intervention or just a medication on the side. So that's one thing I like to bring up in the approach for it.
So we have a few questions here. Will Medicare cover it? Medicare is we have very little trouble with having Medicare approve this type of intervention. So we've been fortunate to have that. There've been a lot of support through that insurance carrier. There's something about ozone injections. If you want to clarify that, but we can get back to that question. What other topics are we thinking about on future webinars? We'll definitely cover that right when we're wrapping up here. And there's a couple other questions. Would you treat shoulder pain? Yes. So shoulder pain is can be very effectively treated with this type of intervention. Chronic shoulder pain, post-surgical shoulder pain, patients who have frozen shoulder, non-responsive to traditional methods, can be helped very much with this intervention.
From a shoulder standpoint, yes, if there's a clear rotator cuff tear that needs to be replaced, oftentimes, that's something that should be done. But many times patients have this kind of chronic nagging or irritation of the shoulder where there's some tendonitis or irritation of the nerve fibers there or the muscle fibers there, but there's nothing really there to sew back together or replace. And that's where stimulation for the shoulder can be quite helpful.
There's a question about MRI compatibility. So many of the new devices that have been coming out and continue to come out have been very conscious about MRI compatibility. So the answer to your question is yes. So that would be a part of the planning process of what device we use, where we're going to place it, etc. So many of the companies and the products that are currently available have MRI compatibility. And it all depends on the different types of MRIs. But that is a good question. And yes, the answer is there has been good advancements there. Let's see here. Most common body parts you see pain, highest success rate. So question is go ahead, do you want to answer this one?
From highest success rate or most common? I mean, highest success rate is a difficult question to answer. And a lot of that comes into the trial. I think that if you have a really good trial where you're getting 90% of relief on your trial, then I'd expect you to have a really good outcome from the implant of this device. If it's kind of 50-50 on the trial, then it might not be as successful as we're hoping for. From a standpoint of common areas, the spine's probably the most common because that's where most of the technology and research really initially started with this. That being said, I mean, knee pain that is either where a patient doesn't want to have knee surgery or they have had a knee replacement and they still have knee pain, or shoulder pain, foot and ankle pain. I've had really good responses to those areas. There was an interesting question I saw about mechanical back pain, related to scoliosis. And so most of the time we think about spinal cord stimulation itself treating the nerves in the spine, but you can have pain from a lot of different structures in the spine here. And sometimes it's more coming from these facet joints on the side here. And that's really a lot of time where we see issues with mechanical pain from scoliosis. And the benefit with some of the peripheral nerve stimulators that we use is we're actually able to treat those joints as if it was any other joint, like a knee or a shoulder, where you can stimulate the small nerves that go into those joints there and block a lot of those pain symptoms. A lot of times in the past, and we still do a treatment called like an ablation or where we zap or destroy the nerve that's going to those joints there. And that can be a very effective treatment for some patients, but sometimes patients just don't respond to that, or it doesn't last long enough. And that's where a more permanent stimulator to provide that type of stimulation long-term is quite helpful.
So we have a few questions about, I see the clarification about the ozone and laser therapies. So some of these, not what we describe as non-traditional interventional pain management methods are good adjuncts. We don't offer them in our practice, but we use them, with other specialists that are in our community, laser therapy and other things like that. So there's definitely a way to provide adjunct therapy. When you talk about like things like spinal cord stimulation, it's probably more isolated to a specific targeted pain that we're focusing on. But generalized treatments can be done to help with myofascial pain, muscle, soft tissue pain, joint pain, with things like ozone therapy and laser therapy. So there's a question here that is regarding a bulging disc in the lower back affecting the sciatic nerve on the right side. So again, that kind of goes through what Dr. Burnett mentioned earlier, is we go through the gamut of traditional pathways, kind of like an algorithm almost of treatments, spinal injections, epidurals, nerve blocks, hopefully not surgical, but if it's necessary, we encourage it if we need to go down that pathway. Or the patients come to us who have had surgery done, and we do these injections prior to something like neurostimulation. If they fail some of the traditional methods of treatment that we can do for them, then neurostimulation is actually a very good treatment option for someone who has a pinched nerve that's in the non-surgical candidate, and they're in a lot of pain. Then we can help deaden that nerve response. So it's a very good way to do it. Is there an issue with going to metal detectors? I mean, every patient gets a card. It's like having a pacemaker. So they usually don't, they allow you to bypass certain lines. So you'll get that card as a part of your identification that you have that device. So, this is very similar, again, to, similar to what a pacemaker is made of.
So there's someone asking about the size of the implants. And so typically any type of nerve stimulator is going to have a lead like this aspect here. And this is a pretty small lead, smaller than I'd call it like a guitar string. And this is what actually has the little electrodes on the tip of it to stimulate the nerve. So the issue is, how do we get power into these leads? And there are two methods, both a receiver in the back or wherever we're placing this, a receiver under the skin like this, or a battery under the skin like this. And I mean, this is this is the size of my hand. It's not that big. It tends to go, when we use these batteries, they tend to be really well tolerated in the back or in the flank here,
or the
usually or in the buttocks there. And usually it's placed in a location where, depending on the patient and how they're built, in a place where it's not going to affect anything else there, just in the soft tissues. That is the advantage, though, of why we use both devices that have a battery that's internal and a battery that's external, if that's a concern for you.
Yeah. And are there any issues with the metal? So there's a question here about hip bone and bone arthritis pain. So if it's specific to neurostimulation, there is different methods to help with that type of pain. Mm-hmm. But there are treatment pathways that can be very effective with this type of intervention. I see one of our it looks like a patient that's actually undergoing a trial is doing well. So we're happy to hear that, and we're seeing more and more of this type of response from our patients. Number one, because selection is important. So we don't offer this to every patient. If they're a good candidate, we do offer it. And we're pretty confident in the outcomes. If we feel this is a good thing for a patient, we'll do the trial, again, non-committal, and then we're able to pursue permanent implant based on the outcome of that. Mm-hmm. And let me see if you missed it. There's a question here about talking about future discussions. So we have a number of different topics that can be discussed, from tendonitis, tendinopathies to other pathologies that we deal with, sports-related injuries, and kind of how to manage these things. So we're hoping that we're number one, we're open to doing receiving any recommendations or suggestions that you all want to hear us talk about, because obviously we're here for you. But we will touch base on some of the more advanced treatments that your pain doctors, that pain doctors are now discovering or have discovered, and we'll continue to introduce those topics to you. Outside of just simple like traditional epidural injections or joint injections, there's a number of different treatments. This is one of them, and hopefully you learned quite a bit from it.
Yeah. So I would tune into all of the communications that we have coming from the office here. We'll keep you updated on when the next webinar will be.
We're going to aim to do it on a monthly basis. So we'll be happy to field any questions in between and maybe bring them up. Maybe next time leave a little bit more time for questions, because it looks like there's quite a few, which we're happy to see. Mm-hmm. So thank you all very much. And this recording for this will be placed on our website, on some of our social media, platforms. So you'll be able to see them again if you need to. Mm-hmm. All right. And any questions, obviously, you can reach out directly to our office. Thank you.
Yes. Thank you, guys.
Thank you, everyone.
Have a great weekend.
Bye now.